Everyone, today we are going to talk about depth of anesthesia monitoring, and welcome to our institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry, and my YouTube channel, Pain Free Partha. So, what is depth of anesthesia? Is a probability of non-response to stimulation. So, if you stimulate, what is the probability that the fellow will not respond? What is calibrated against? Strength of the stimulus, the difficulty of suppressing the response, the drug-induced probability of non-responsiveness. I will tell you now, you can have a strength of the stimulus. It is sternotomy or herniatomy. So we can have non-response to stimulation for a herniatomy and for sternotomy at a similar depth, no? So depth varies there. Availability and constant contraindications of drugs. So you have got the difficulty in suppressing the response. So this patient is not good for opioids. This patient is a COPD patient. This patient cannot have some other drug like nitrous oxide. So difficulty in getting the suppressing the response. The drug-induced probability of non-responsiveness. The drug may not act on the brain. So these are all the problems we get, against which we have to do a non-response for a stimulation. This is what is the depth. We can control, if we can control these two, we have achieved that. That is what Miller tells. What tells? Hypnosis, that is by IV agents or inhalation agents. Analgesia by opioids or nitrous oxide. Some other mode we can have also. So the first time, Arthur Gödel in 1920, what he did was, he proposed one stages of anesthesia. Okay. Stage 1, stage 2, 3, and 4. Stage 1 means everything is fine. Mild analgesia going on to a level of some amnesia. Okay. Respiration is fine. Ocular movements are normal. Pupil size is normal. There is no suppression of reflexes in stage 1. Okay, can we operate in stage 1? There is no suppression of reflexes. Patient is not anesthetized. Is slightly conscious. Only pain relief is there. No, we cannot operate. Now it goes to stage 2 where there is a delirium. Respiration becomes irregular and the eyeballs are moving, patient is moving like that, some sort of delirium, some sort of nausea, vomiting, involuntary movements, but still the BP and pulse rate will vary, still there are reflexes. Can we operate? No. Let us come to the stage of surgical anesthesia. 1, 2, 3, 4, where slowly the respiration becomes regular and becomes slowly apneic towards the stage of medullary paralysis. So they want here only at this or at this stage where pupils are not moving. This is good normal, reflexes suppressed, no involuntary movements, BP is stable. That is what we want here for anesthesia. This is only for ether. That is what we should know. Only we pour ether in the Schimmelbusch mask and start inducing and getting with ether only. This is possible. Start with morphine. Pupils is gone. Nausea, vomiting is gone. Start with propofol. Something else. Everything is gone. So this is only for inhalation agent with ether. So when the muscle relaxants came in 1950s, Professor Gray and his colleagues developed the so-called Liverpool technique, intentionally light anesthesia with profound muscle relaxation. Muscle relaxation was given, DTC was given, dibocuranin, and anesthesia was light. So this was done as a Liverpool technique without awareness about awareness. So why do I know one surgeon, an anesthetist, they did one lap ovarian surgery. And that hospital did not have proper inhalation agents. So it was done some 10 years ago, and they gave a very mild narcotic like Fortrin or Tramadol, and they did the surgery, GA, and the patient did remember all the events, right from putting the knife, everything she remembers. So this is not the way, this is complete awareness. The essential features of a successful general anesthesia: reversible loss of consciousness with lack of movement, lack of awareness, lack of recall. unresponsive to pain stress, should not remember, he should not recall, he should not be aware of what has happened, and he should have good pain relief, and he should not move during the operation. This is how things should move for a good GA. Now you can see here, surgery will produce a painful stimulation. This will cause arousal, and this will cause increased BP, heart rate, sweating, and tears. Those days we used to see tears. Anesthesia is not enough. Give some petadine or something like that. So those days were there. There is sweating. Those days is gone now. We used to clinically judge the depth of anesthesia. So arousal, all these things happen, and awareness, memory, and recall. So if the arousal can cause movement, this part is only blocked by muscle relaxation. This arousal causing awareness, memory, and recall has to be blocked either by general anesthetics or opioids. Sometimes you can have adjuncts, NSAIDs, helping the general anesthetics to have these things. So that is how it should run. If a patient moves under general anesthesia, okay, it's a very good word sentence from Miller. If a patient moves during anesthesia, if we give relaxants, it is good for the surgeon and anesthetist, because surgeon starts operating again the laparotomy. Anesthesia is not bothered because everything is fine. But what for the patient? We need to give narcotics, benzodiazepines, or agents. So that is how the difference is that. This sentence in Miller is enough to understand what is that. If a patient moves under anesthesia, if we give relaxants, it's good for the surgeon and anesthetist. But for the patient, that is what is the depth. Narcotics, benzodiazepines, or agents. So we need to get the depth with two different completely things. One is intravenous anesthesia and another is inhalation agency. Both should be there. And even for both, the depth should be complete. Monitoring anesthetic delivery is not the same as monitoring anesthetic effect. Now we know, yes, we have got 2% isoflurane is going, 1.6% desflurane is going. This is monitoring anesthetic delivery. It is not the same as monitoring anesthetic effect. What is the effect this has produced? An entitled concentration of 1% of sevoflurane is monitoring anesthetic delivery. Now, what is the monitoring anesthetic effect? That is different. That is what is given by so many monitors. Alpha, the normal EEG is alpha, beta, gamma, delta, and theta, and thalamus, cortex, thalamus, and so many things. To achieve the optimal level of GA, it is not possible to adjust the volatility on the basis of an online EEG. Importance of end-tidal as a standard of care, yes. Because we have proved the DTA concentration of 0.7 NAC awareness is unlikely to have patient awareness. Three properties of agents. Steep dose response curve of the anesthetics. Opioids may not change. We can easily monitor. These are the three things which we are thinking that, okay, 0.7 NAC means awareness is unlikely. Clinical signs of bleeding is there. Has the vaporizer level decreased, or we have failed to switch it on? These are the things that makes very essential to have ETA, because if you on it 2% and the ETA is not showing, then it means as the vaporizer level decreased and we have failed to switch it on the isoflurane itself. So in and out. The action of the general anesthetic on a molecular level are reflected on the veins, low voltage, high frequency, to a slow wave EEG. Okay, now goes into EEG burst suppression pattern. Suppression, burst suppression. This is what is anesthesia. Okay, very important. Mechanisms of general anesthetic drug is not equal to mechanisms of general anesthesia. General anesthesia at the molecular level is different. General anesthetic drugs may cause GABA. That is a two different things. I will come to the molecular mechanisms of general anesthesia in a different video. So what are the areas of importance? Thalamus and this spot here. Temporoparieto occipital junction. These are the areas of importance. Now, what is isolated forearm technique? Now, you have given propofol or something else, a start agent, and given muscle relaxants, put the tube. Now, at the time of muscle relaxation, you have given this thing like this, tourniquet, thinking that the muscle relaxants will not go here. Okay. Now you started putting an halothane or isoflurane or whatever it is. Now you tell the patient, move your left thumb. If the patient moves the left thumb like this, now there is no anesthetic left because he has understood and he is moving. He has understood he cannot move here because your vecuronium is acting. Here he will move because your vecuronium is isolated by a forearm technique. So that is how it was easily detected those days. Isolated forearm technique. Now we go to anesthesia awareness. Is especially a different topic. Now I will tell what is a normal EEG. The normal EEG, there is no burst suppression. I'm going here now. You see, this is the burst followed by suppression, burst followed by suppression, burst followed by suppression. This is what means the patient is not conscious. Very simple. EEG, burst suppression, patient is going slowly, slow activity of the brain. Now, I've already told how you are going to monitor this depth of anesthesia. So there should be a virtual sensor, and this is telling something like it measures EEGs and tells some numbers. Now, bispectral index is the gold standard, this monitoring. It's a method used in anesthesia to assess the depth. It analyzes EEG and provided a numerical score, 0 to 10. Reflecting the patient's level of consciousness. Okay. Now you are connected here and there. Now you see here, you are connected here, and it analyzes the EEG and gives a number. The 0 to 40 means deep hypnosis. We need to keep around 40 to 60 of BIS. BIS, there is no unit. This is a dimensionless number which is created by the monitor analyzing your EEGs. Understand? So that is what is the BIS value. So why do you want to have this depth of anesthesia monitoring and BIS guided things? It may reduce the risk of intraoperative awareness. Now you keep it around 40 to 50. Yes, we are sure that there is no awareness. BIS to guide anesthesia decrease the incidence of post-operative cognitive dysfunction. Now there is no awareness, clear. So there is no POCD. And you need to give little less anesthetics, and recovery is better because all these things are there. Because we are giving less anesthetics, possibly a PONV is also less. There are two drugs, nitrous oxide and ketamine, because ketamine will cause another completely different type of EEG changes. So this is not very good for this monitoring. And this is not good in challenging in patients younger than 6 months. Problem is also with temperature. 1.2 degree. If you come from 36 to somewhere around 33, now you see degrees Celsius, another 5 units with decreases. So you are run to 45 when it is actually 50. Neurological diseases. Already patient is epileptic with EEG changes. Surgical diathermy. Beware the surgical diathermy is a problem. So monitoring the surgical diathermy is a problem. So these are all the problems and limiting factors with regard to BIS monitoring. What is BIS monitoring? Bispectral index. BIS is what it does. It analyzes the EEG and gives a dimensionless number of 0 to 100. These are all the problems of BIS. What are the advantages? Yes, we can decrease the amount, we can decrease the agent amount, we can have better recovery, better PONV results, and titrate this to decrease completely or eradicate awareness. This is about this. Now we come to entropy. It did not utilize as EEG data. Provide two indices. There is something called status entropy and set entropy and response entropy. Response entropy, what it does is EEG and EMG of the frontalis muscle. EEG and EMG of the frontalis muscle. You are keeping the same electrodes here. So what it does is, now you can see there are two things. State entropy is up to 90, 60, 40. Here you can keep here. Response is slightly moving towards understanding nociception. Now you see your thing is here, but here it is slightly on the more means. You need analgesics because your response entropy is a little higher. That will correlate more towards nociception. Status and state entropy is more towards depth of actual inhalational agents. This is agents, this is narcotics. In simple terms. This is our study, Brigesh Ravi Shankar, Hemant Kumar, Parthasarathy. What we did was, we did all lab coli. Okay. Now we put epidural in one group and GA, which was entropy gated to keep it at around 50. Okay. Now, how much reduction in sevoflurane is there when we give epidural also? So sevoflurane need to keep the same entropy was 44% less. So think, if you give epidural with GA, your sevoflurane requirement is 44% less. What we did, this is what is influence of epidural anesthesia on entropy guided GA with sevoflurane. So this is about entropy, because state entropy and response entropy. State entropy is anesthesia's, response is nociception. The narcotrend algorithm is based on a pattern recognition of raw EEG. It classifies the into the stages from A to F. Okay, A is awake and F is complete silence. Newest, the again narcotrend index 100 to 0 electrical silence. Vast amount of information. The cerebrogram, the raw EEG, the power spectrum, several derived EEG parameters. Now you can see this is the type of narcotrend. We can keep the electrodes like this. Now you see narcotrend is a monitoring system, the depth of anesthesia, 0 to 100. Real-time assessment, primarily used. Real-time monitoring relies on correlation with other indices. This is narcotrend. This is state and entropy. This is bispectral index. Auditory evoked potentials. Now I will tell you simple words. Now you have got some EEGs. Okay, EEG is running, and the patient is having general anesthesia. We have kept the BIS or something like that in around 50. Okay, now you give some sound to the ears to the patient. Okay, you give an audio stimulus. What is the response in the EEG? That is how much the patient is in depth. That what tells the AEP monitor. This is PSA 4000 monitor, the value of index from 4 EEG channels. Patient state index, again the dimensionless number 100 to 0. The index of consciousness monitor, there's one more monitor, 3 surface electrodes. The IOC monitor, index of consciousness monitor, it tells burst suppression ratio, signal quality bar, percentage of EEG, IOC index, everything EEG. This is IOC monitor. There is something called cerebral portable, wireless, superb monitor. Again, same thing, 0 to 100, scale 40 to 60. There is some AI into it, monitoring depth of anesthesia based on hybrid features and recurrent neural network. Now, what are the problems? Here, the problem is transition. Now, you give propofol agent or something like that. The transition is irregular. From 90, the patient is conscious. It doesn't come to 50 slowly like that. It's fantastic. And also, patient is unconscious. Okay, the patient is going to be extubated. Now, tube is in. You do a suction, from 40 it comes to 90. So that is the problem. The transition from 40 entropy it comes to 90. So the transition is a problem. The device is inside. There are a lot of false values. Muscle relaxants may confuse. Cardiac, pregnancy, children. These are all the problem areas of BIS. Yes, we know we are only measuring frontal EEG. Okay. There is a question of some thalamus or all these things. We tell that this may be representing the thalamus, this may be representing your somatosensory cortex. Isolated forearm studies indicate awareness without recall. Hearing otherwise is not uncommon. Do not reliably detect some episodes of consciousness. Use of deep learning algorithm to classify EEG correlates of anesthetic stimulus. These are all the hassles of monitorings. So why we need? Yes, we need to decrease the awareness. We need to decrease the amount of drug use. We need to increase a better post-operative extubation time and period and PONV. Types are so many. Isolated forearm is the best one. Then comes bis entropy narcotrend and others like index of consciousness, PSA 4000s. There are a lot of problems. The main thing is about transition. Thank you all and welcome.